Welcome back to the Dr. Geo Prostate Podcast. Today's guest is Dr. Katz, chairman of urology at NYU Long Island and a nationally recognized expert in prostate cryotherapy. He played a key role in securing Medicare approval for cryotherapy in men with radiation recurrent prostate cancer. Dr. Katz has published over 130 scientific articles and is the author of 2 trusted books for both patients and clinicians, The Definitive Guide to Prostate Cancer and Dr. Katz's Guide to Prostate Health. In this episode, he walks us through the evolution of cryotherapy from whole gland treatment to today's more precise focal therapy and explains who's the right candidate. Let's get into it.
Before I proceed, I just want to clarify that this podcast and all Dr. Geo content is separate from my faculty position at NYU Long Health. The views and opinions on this podcast are my own. Our guests and sponsors are curated by me and not affiliated with NYU Long Health. Sponsors are a way for us to provide high quality information at no cost to you so that you can take better charge of your prostate health, testosterone, and erectile function, and also how to live better with age. Welcome to the Dr. Geo Prostate Podcast. I'm your host, Dr. Geo. As you know, the intention is always, how do you improve your prostate health? What are your options as it relates to all prostate problems, prostate cancer, and how do you live better with age? Today's guest is the one and only Dr. Katz. Aaron, thank you so much for being on.
Yeah, my pleasure, Geo. Good to be with you today.
You know, this is full circle for me. The reason for that is because there have been 3 people very influential in my career. To start with Robert Valenzuela. I started with him over 20 years ago. He then connected me to you when you were at Columbia University Medical Center, the Center for Holistic Urology.
Right.
There. And then you hired me, and that's where I learned a lot about everything under your mentorship. And then, of course, Herb Lepore, who hired me at NYU. And I've had both Robert and Dr. Lepore on already on the podcast, and we just needed you to come on. So I can't tell you how thrilled I am to have you on the podcast.
Well, thanks, Geo. You know, you've done a great job, and I hear time and time again from many of my patients how wonderful you've been as a resource for them in terms of your integrative methods and, you know, the way that you were educated, which was different than the way that, you know, that I was going through medical school, and your background is different. And I think adds a great dimension to the overall well-being of patients. You know, time and time again, we see patients that come in with prostate cancer, and of course, with Biden's, you know, the ex-president's diagnosis, it's on everyone's mind now. Of course, he has very advanced prostate cancer. Not all prostate cancers, as we know, are the same. Some are the very fast-moving, aggressive ones, and some are slow and don't need to be treated. But, you know, you have helped in so many ways in navigating for people to either get treatment or to go on to a holistic method of incorporating things in their diet, exercise, and other mind-body therapies. And it's also interesting that we see so many men with non-aggressive prostate cancer today that have so many other health-related issues, but they tend to focus on the prostate cancer. But yet, you know, they're significantly overweight, or they're significantly dealing with high blood pressure, kidney disease, diabetes. They're smoking, they're not taking care of themselves. And yet this is what they're focusing on, this small amount of prostate cancer, which, as we know, many of these cancers, not all, of course, but many of them are not going to impact someone's life. And we need to help. And this is where you've been very, I think, very key and very instrumental in helping educate people about, you know, their whole body, you know, and rather than just focusing on what's below the belt, which is important, of course, you know, sexual health, prostate health, of course, but you know, we need to, I'm a firm believer in, you know, in healthy aging, not anti-aging, but healthy aging. We're all, but how can we do it in the right way? And, you know, in your methods of incorporating a proper diet and proper nutrients and vitamins, which I do every day of my life. I mean, I try to exercise every day. I mean, 6 o'clock in the morning, I was in the pool. It's
Uh-huh.
raining. It's raining outside. It's cold out. You think I want to go get in my car and jump in a pool? But you know what? I do it because you got to push yourself,
That's right.
And
That's right.
then I take my vitamins and then I come back and I'm invigorated and I start my day. But that's just me, and I'm not saying everybody's got to jump in a pool every day. And if you're not a swimmer, certainly don't do that.
You
But
know that jumping into a cold pool is therapeutic. I don't know if you know that now. So I don't know
yeah,
if you're up for it, but it's cryo. It's a form of
oh yeah,
cryotherapy.
oh yeah. I have a whole bunch of patients that believe in the cold plunge, and they have these
Right.
either go to a center or they have them in their house. One guy I know has it in his house, a cold plunge, stimulate and improve your immune system. But I think as practitioners, and I know you do this as well, we need to incorporate these things into our own lives to help our patients to see that yes, if you have prostate cancer, and unfortunately with our ex-president who has a very aggressive form and needs long time treatment, and it's unfortunate that the testing apparently was not done. And and that I've been a very strong advocate and work with an organization called Fans for the Cure, which is to promote early detection of prostate cancer. And since I'm a resident, which is back in the day in the early 1990s,
Wow.
PSA is still the gold standard. When
It
it came
is.
to clinical utility, it was in the late 1980s, and then it became really in favor in the early 1990s. And it was the digital exam and the PSA. And if you read the stories about Biden, apparently, I don't know about his PSA, but apparently he had some urinary issues, and somebody was brave enough to do a rectal exam on Joe Biden and felt a nodule. And then they're like, hey, maybe we should do a PSA. Oh, probably. I don't know. I don't have information here. I'm saying probably.
If it was you, Aaron, who you are his urologist and you have the ex-president in your office, how would you go about telling the president, I need to check your prostate? Would that,
Bend
I wonder.
over, drop your pants, be a man, and put your elbows on the table, and I'm going to do a rectal exam on the
Right.
president. Are you kidding me? I don't want to miss anything. Okay, Geo, I'm
Right.
not.
It's like any other patient, right?
I'm doing a free PSA, a free and total PSA, a
Yeah.
digital exam, and being as thorough as I can. And and I don't know if it was. They say it wasn't done. Okay, it wasn't done. It should have been done. Can't go back in time, but and the point being that we do need to be proactive about our health, our overall health, and for prostate, and that's what your field is and mine. I'm a very firm believer, and I don't care. They say, "Oh, you stop testing after 70." Nonsense,
Nonsense.
guys. I have guys, and you know this too. You have many patients that you see that are in their 70s and 80s, late 80s, that are active, both physically, sexually.
Yeah.
It's a different era now. People are taking care of themselves. And what, I'm not going to do a PSA test, a blood test to check. And God forbid, it's super high, and you want to get treated. I mean, you want to knock it out.
I
And so,
wonder. I wonder if you think that the occurrence with the president will change our guidelines and raise the age to maybe, I don't know, 75 or 80, or should there ever even be an age where you stop screening for prostate cancer? I wonder.
it's a great point. I think what will change, unfortunately, and it's a good point, and hopefully the NCCN, the AUA, and the American Cancer Society will come out with new guidelines about that and stop this cutoff thing. I think, but I think what will change, unfortunately, is a lot of men who are now super anxious about it, who we believe are good candidates for active surveillance because they have a grade group 1, Gleason 6, low PSA, MRI doesn't show anything bad, and we say, you're fine, let's go on active surveillance. I think a lot of these guys are going to go, wait a minute, I don't want to end up like Biden.
Yeah.
I don't want to be that. Okay, you're telling me right now I have cancer, you can knock it out with a cryo needle, a radiation, or take it out, whatever, a laser, a HIFU. We have lots of different ways of ablating cancer, as you know, or removing it or radiating, whatever it may be. That a lot of people, and I've already seen it. I've already seen it this week, and it's
Mm.
from a lot of wives and spouses too,
Yep.
are saying, He doesn't want to be like Biden.
Yeah.
I don't want him to have disease in the bone, Dr. Katz. So I know you're telling me it's not going to grow for many years, but I don't want to worry about that. And I
Yep.
think that is something that we might see a change in.
Yep. Hey, Aaron, take us back a little bit.
Yeah.
Center for Holistic Urology.
Yeah.
We're talking about early 2000s where it was not in vogue to do holistic and integrative medicine.
Yeah.
It was poo-pooed quite a bit, actually. I mean, I struggled, I have to say. And the only support that I got back in the day at Columbia was by Dr. Aaron Katz at the time, who is his natural what? What is it? Naturopathic doctor? What are we doing here? By everyone else.
Yeah.
So why the interest? How did that start for you in terms of appreciating that, there might be something else that can help these patients, some holistic lifestyle, natural things, supplements, something? How did that start for you?
It all started, sometimes things change on a dime with a phone call.
Yeah.
And your life. And I was very early in my career. I had just finished my fellowship with no practice. And the office got a phone call from the late Dr. Atkins.
Robert Atkins. Yeah.
Robert Atkins, the diet doctor who had a center in Manhattan, the Atkins Center. And they said, look, we have a lot of prostate patients here, a lot of prostate cancer. Would Dr. Katz like to come down once a week on a Tuesday and see all these patients? Now, I had no practice. Okay. So I'm like, what else do I got to do? I'll go down. So I go down there. It was on, God, I think it was like 72nd and Lex. Anyway, it's a nice center, third floor, go up there. And they got a ton of prostate patients, and they're prostate cancer patients. And they're all taking these herbs and diet and vitamins. And I'm like, and I didn't know it. I mean, I was trained as medical school residency. You know how much training I got in vitamins and herbs?
Zero.
Nothing. 0.0, maybe one lecture. I go down there on a Tuesday and I'm seeing all these patients that are not doing surgery, not doing radiation, and they're doing holistics. And you know what? They're doing fine. They're doing well. And then I go back on a Wednesday up to Columbia and I'm taking out their prostates. And I'm like, there's something not right here. Okay. This doesn't make sense to me.
Right.
These guys are down here doing so well, and they're just following it, and they're doing this herbs and this and that. There has to be something to this. Let me take a look at this. And I had a lab at the time at Columbia, and I with a PhD, and I said, look, they're taking this one herbal compound. It's called Zyflamend. It's an herbal anti-inflammatory. I said, let's study this in the lab. Maybe there's something to this. I don't know. But everybody's taking this thing down there. I never even heard of it, Geo. Sure enough, I bring it back to the lab. We put it, expose it to prostate cells. And sure enough, it has an effect on the growth of the prostate cancer cells. So I called the company and I said, look, Paul Schulich and Tom Newmark, they own the company of New Chapter. And I said, look, guys, this is Aaron Katz from Columbia University. You're calling us a vitamin company? I said, we're finding something here. We'd like to do a clinical trial. We did a clinical trial. It was effective. And that's honestly, Geo, that is exactly how it started.
Amazing.
It started again by the science, by looking at the science. And you're right. Doctors were like throwing tomatoes at us at the AUA. These urologists. You're either going to take the prostate out or you're going to radiate it. That's it. No surveillance, no holistics.
Yeah.
And then people are like, Dr. Katz, people are going to call you a holistic doctor. You're never going to see any more patients. I said, you know what? I am an integrative doctor. And then I started reading books about it. Then I started listening to Andy Weil about it. Then I started going to conferences. And I went into the rainforest to learn about herbs. I went to Japan in Sapporo to learn about a mushroom compound over there, AHCC, which
AHCC, yep.
They had a whole conference on these medicinal Japanese mushrooms. I'm like, what? Medicinal Japanese mushrooms? They're like, oh, yeah, it boosts your immune system. I knew nothing about it. Brought it back. We started using it on our patients with great effect. So
that's right.
That's really how it started. And I was a loner. And you came along and you helped me, and we got it going really well.
Yeah, that's amazing. Yeah, I'm still in touch with Tom Newmark. I actually
Really?
we were there last. We were at his. He lives in the middle of the forest. Actually, he has
Yes,
a home there. So we stayed at his place.
in Costa Rica.
And yeah, New Chapter, you may know, and Zyflamin, they're owned by Procter and Gamble now. So
I know
they
that.
were bought.
Yeah,
And we were discussing of wondering if the process of making their supplements, including Zyflamin, was the same, because they're not using their turmeric, is my understanding, which comes from a certain place in Costa Rica. So yeah, so that's how that started. And so simultaneously, I'm assuming, maybe you can expand on that, you were doing cryo, which wasn't around for that long at the time. So what's the history with you doing cryo? I mean, you've done it longer than anyone I know.
absolutely right. In 1994, my chairman at the time was a Dr. Carl Olson, who was a phenomenal surgeon who recently passed away. But he was taking out prostates all the time. And we were doing lots of radiation or prostatectomies. And we didn't have any real solution for patients who had radiation and it recurred. And then he heard about this technology
Was
using.
prostatectomy not an option there,
No,
Aaron?
not really. Not really. You can't really take up, you can, but it's fraught with a lot of danger and a
Yeah,
lot of complications. So
right.
we decided, well, not that he said to me, I heard about this technology where there's a needle or a probe connected to a gas that if you put it at high pressure, it will freeze cancer. They're doing it in liver. I don't know, maybe you could do it in the prostate, okay? But don't do it, only do it in patients that have had radiation first, because I don't want you, he didn't want me to like take the prostates away from his surgery.
Right, right.
So in 1994, in August, I did my first case. Okay, so how many years ago was that? That's almost 31 years ago. Okay, yes, 31 years ago, and I still continue to do it because it was very powerful. Now I was doing it where I would treat the whole prostate. Okay, but we didn't have the MRIs that we have today,
So
and
there was no such thing as focal cryotherapy at the time.
no. No, there was not. I was doing the whole prostate. I started doing some focal therapy, and I brought some cases to the AUA one year in a paper, and again, almost got thrown out because, oh my God, you can't do that. But, back in the day, it was difficult. But nowadays, we have an MRI platform, and I'll put my NYU hat on. I got my NYU thing here for a moment because the NYU radiologists were really good at developing the ability to see these small lesions in the prostate that now we can see. And we also have a computer guided platform where we can take the MRI and fuse it with an ultrasound to do what's called a fusion biopsy. And we can see exactly where that cancer is. And now, if you just have cancer in one area or quadrant or lobe of the prostate, you can just, as you mentioned, focally freeze it. So instead of me freezing the entire prostate, we can freeze it. It takes about an hour to do. Patients go home and boom, no radiation.
When did that begin? When did the focal aspect of cryo begin?
I would say really about probably 5-6 years ago.
Oh, really? Only 5-6 years ago?
Yeah,
It's
yeah,
interesting. Yeah.
yeah.
Okay.
And Dr. Lepore, you mentioned his name. NYU, the chair, has really done a lot of work in bringing that to the forefront. He's a real doctor scientist and collects data very well, and looked at this and really brought it to the forefront. And now there's a whole focal therapy society, and now everybody is believing that a focal therapy, whether it be cryo, which has the longest history, laser,
Many options.
nanoparticles,
Yeah.
electro needles, it's called IRE, irreversible electroporation, are great ways of treating not every prostate cancer, but ones that are localized where you don't need to treat the whole gland like with radiation or with surgery. You can do focal therapy. So Yeah, I was definitely a pioneer back then and still feel that it has a great role for many people.
Who has done cryo longer than you? I don't have a name.
Probably no one right now. There
Yeah.
was a guy named Jeff Cohen. I don't think he's doing anymore. Or there's a guy named, yeah, I think probably nobody.
Yeah, exactly.
Actually, there's a doctor in San Francisco, Katsudo Shinohara. Katsudo Shinohara. I understand he's still working. He's probably in his early 70s, I believe. He is probably just as long as I am. I
How
mean,
has
shouldn't I get an award for that?
I listen? Well, you're
I mean,
talking to the wrong person because I hold you up very high as a pioneer in cryo, and certainly even in holistic urology.
yeah,
I mean,
yeah.
it's excellent combination. And again, I don't know. Maybe I'll
That
have a statue of you here or something. Hey, the history of cryo, right? So I remember back in the early 2000s, and it's a whole lot different than it is now. And of course, I'm not a surgeon. I cannot get into those details as
sure.
to how it is different, but a different gas was used early on. It was, like every new procedure was a little bit clunky. Tell us
Sure.
about that. Hello, friends. I just want to give a warm welcome to our next sponsor, Lynx DX. As you know, 1 in 8 men will develop prostate cancer during their lifetime, and screening does matter. But common approaches like PSA testing alone can be misleading and oftentimes is elevated for reasons that are unrelated to cancer. That's why Lynx DX developed My Prostate Scorer 2.0, which is a simple, non-invasive urine test that helps you understand your true risk of having clinically significant prostate cancer. We're talking about Gleason 7s or higher. And PS2 uses 18 unique biomarkers to give you a personalized prostate cancer risk score. The test is accurate, whether your urine is collected in the doctor's office or at home, and is designed to help you and your doctor understand what is the next step, whether there is more testing involved, imaging, or a biopsy. Talk to your doctor today to see if MPS2 is right for you. Visit lynxdx.com, that's lynxdx.com, or look below in the show notes for the Lynx DX link. Hello, friends. I just want to give a warm welcome to our next sponsor, Lynx DX. As you know, 1 in 8 men will develop prostate cancer during their lifetime, and screening does matter. But common approaches like PSA testing alone can be misleading and oftentimes is elevated for reasons that are unrelated to cancer. That's why Lynx DX developed My Prostate Scorer 2.0, which is a simple, non-invasive urine test that helps you understand your true risk of having clinically significant prostate cancer. We're talking about Gleason 7s or higher. And PS2 uses 18 unique biomarkers to give you a personalized prostate cancer risk score. The test is accurate, whether your urine is collected in the doctor's office or at home, and is designed to help you and your doctor understand what is the next step, whether there is more testing involved, imaging, or a biopsy. Talk to your doctor today to see if MPS 2 is right for you. Visit lynxdx.com, that's lynxdx.com, or look below in the show notes for the Lynx DX link.
Yeah, I mean, there were basically two gases that were used, one to freeze, one to thaw, argon to freeze, helium to thaw. The platform that I use now just uses argon to freeze and to thaw. It's very quick. It also has the ability to monitor the temperature in and around the cancer so that the margin is frozen and the tumor is dead. You can see the temperature dropping very rapidly. I did a case with a resident yesterday who had never done a case, and I showed him how to do it, and he's amazed that you can really see how cold it gets within the tumor itself. We got down to minus 90 degrees centigrade. And also you can measure the temperature near the rectal wall so the rectum isn't damaged, and the external sphincter so the patient remains continent and doesn't leak urine. So I think it's the advances in ultrasound, which we can really see very well, advances in the needle. It's no longer a big probe. It's a very thin needle. It's almost like an acupuncture needle, really. very thin. There's no bleeding. Knock on wood, never transfuse the patient. Goes very sharply directly into the prostate. Quick freeze, measure the temperature, and you can spare the nerve bundles outside so men can remain potent. You can see the temperature in the nerve bundle as well so it doesn't get cold. So I think those are the main advances there. And then also, of course, combining it with your MRI and your biopsy. So all those strategies are really great improvements.
What were the side effects then versus now? There had to be a lot since it was a new procedure versus what we see now.
Yeah, I mean, then we didn't have the ability to warm the urethra, the urinary tube, which runs in the middle of the prostate. So oftentimes that would get frozen. That never happens now. We have
Sure.
an excellent warmer. So patients don't have to worry typically about prolonged urinary difficulties, urinary incontinence, urinary tract infections. Those are pretty much gone by the wayside. We also have the ability to really, with the ultrasound and the thermocouple, look at the rectum to make sure that the ice doesn't go into the rectum so there's no rectal damage or something what we call a fistula. We don't see that anymore. We're able to spare the nerve for erection, so potency is spared in most cases.
And potency is 100% in cases where it's a full freezing the full gland. Is that correct? Or has that changed?
I would say it's not 100% potency, but it's pretty close. You know,
Mm-hmm.
nothing's 100%, right? But it also depends upon the man's erection ability before the procedure. What was that like? But it's very good. It's very good. Yeah.
So fast forward, I don't know, 30 years, more than 30 years. What's the situation now with focal cryotherapy, and how often do you do full cryotherapy of the whole gland these days?
Well, again, with the MRI, we are able to do focal in the majority of cases. I would say almost 90% of the cases that I do nowadays are focal. The cases that I do that require full gland ablation are typically those that are radiation and they recurred, although we're able to do focal in them as well. But if you have a really bad case where there's a lot of cancer, it's difficult to do focal in those particular cases, and you have to do a full gland ablation.
Got it. And in some cases, I mean, it used to be that it was 100% ED, maybe because you couldn't spare the nerves back in the day. In some cases, let's say they have a good shim score and they function well sexually. It is possible when you do a full gland these days that some of them can have full erections after cryo.
Yes, absolutely. Absolutely. Yes.
So patient comes to your office. Who's the right patient to do focal ablation? And I think we need to actually expand on that. What does focal ablation mean? It sounds like, if you don't know, that you're just treating the cancer and that's it. But that's not it. You're treating what?
Well, I do tend to think that with focal ablation, you have an idea of where the cancer is located, whether it's on the right or the left, on the top, on the bottom, on the side of the prostate. But you also want to treat the margin around the tumor to make sure that you will not have what's called an in-field recurrence, where you'll make sure that there's no ability for that cancer to return. And so it's not just zapping the cancer spot, but it's the spot, and then usually about let's say 1 centimeter around the tumor itself.
Okay, so that clears up my understanding a little bit. I was under the impression that if there is, let's say the prostate, there's two lobes, and if most of the cancer is in one lobe, let's just say is on the right lobe, and there's a few spots there, I was
Yeah.
under the impression that you have to treat the whole right side, not just the cancer itself.
No, not necessarily. No, Gio, you really don't. You can just treat and conform your ice just to that particular area. You don't have to do what's called a hemi ablation anymore, where you're treating the whole lobe. Now, again, it depends on the situation and how much cancer there is on one side. And if there's a lot of cancer on one side, you may want to treat that whole lobe.
I see.
But, the nice thing about this as well, Geo, that you should know, and folks that are listening that may be interested in this, and I will say that I'm a board member of the Focal Therapy Society, and there are now many doctors around the country that do this. So that's really great to hear, and it's part of training programs now. That if you were to do this procedure, because a lot of patients say, well, if I do it and it doesn't work, then what? Well, the then what is you still have the options of having another freeze, having radiation, or having your prostate removed. Whereas if you had, let's say, radiation, as I said earlier, you're not going to really have your prostate removed. It's just too difficult of a procedure. Not that you couldn't, but it's difficult and it's fraught with danger. And if you have your prostate removed, well, you're not going to have any more surgery. You might, and it does come back, you might need to have some radiation for those patients. But a lot of patients that choose surgery didn't want radiation. And now you're saying, well, you took your prostate out and it came back, and, well, you might need to have radiation. A lot of the patients that I see for focal therapy are very well educated people. And they're like, look, I don't want to have surgery. I don't think I need surgery, and I don't want to have radiation. And that's why they come for the therapy, for the ablation.
Got it.
I think it's also, these days we're much better at accurately predicting the type of cancer that someone has. Our biopsy strategies are better. We can send your biopsy for a DNA analysis. A half an hour just before you and I started talking, I was talking with a company that has a new AI. Everything in medicine is going AI, right? They have a new AI platform where they can look at the biopsy and see what is the best type of treatment for you, whether or not you need hormones, how aggressive your cancer is, what's the DNA analysis of your biopsy. These are things we didn't have before. We can look at the biopsy and tell you from the DNA of your biopsy if it's aggressive or not. Do you need treatment or not? And now we're coming up with new platforms to tell us maybe you should be best with surgery. Maybe you should have an ablation. Maybe you should have active surveillance. Maybe if you have radiation, you should have hormones or you shouldn't have hormones. So we're much better today than we were even 5 years ago at analyzing the tumor and really getting a sense of the biology of that tumor and what's the best treatment for that patient.
I keep saying that if you have to have a cancer, maybe prostate cancer is the best one to have. And this is the best time to have it relative to even 5 years ago, for all the reasons that you've highlighted.
Yeah, for men, actually, the most curable form of cancer is testicular cancer, believe it or not. It's almost 100%.
Right. If it's caught early enough and things like that.
Even if it's not, even in advanced testicular cancer, the cure rates are extraordinarily high. You look at Lance Armstrong. He had a metastasis to his brain from testicular cancer, and he did the Tour de France a number of times. Amazing. But you're right. I think, though, that this saying of men that are going to have prostate cancer are most likely to die with it than from it is not always true, as we were discussing with Biden. I mean, I'm not going to predict anybody's lifespan on this earth, but he has, obviously, from what we hear, a very aggressive form of cancer. It's a Gleason 9. It's in his bones. That will impact his lifespan, no doubt. No doubt.
Yeah,
Not
absolutely.
saying he's going to die tomorrow and he could live many years, God willing. But, you have metastasis of your prostate cancer into your bones, and if it's in multiple spots, that's absolutely going to affect your life.
Particularly at 82 years old, when he's already a bit feeble and doesn't look doesn't look too healthy at that age. A lot of 82-year-olds I see are in great health, but it doesn't seem that that's the case for him. So I think that between the cancer and the aggressive treatments, Aaron, I mean, the hormone deprivation treatment in a man that's 82 who's already weak and has some level of dementia, you have to assume that that's going to exacerbate.
100%. And, we know, one of the dreaded things that hormone therapy can do, besides its possible effect on your heart and on your brain is on your bones.
Yeah.
And, you look at pictures of Biden now, and when, as we get older, osteoporosis sets in, and your stature isn't as tall, and, your vertebral column isn't as strong. And if you start adding on hormonal therapy, which he's going to need not for a few months, but for a long period of time,
Yeah.
that will have an effect, unfortunately, on the mineralization of his bone, and put him into some osteoporosis there. If he's, I'm sure they're going to give him agents to prevent that, beyond the calcium and vitamin D, of course, but there are agents that can help to keep the bone healthy.
Yeah, absolutely. Including strength training exercise, which I wonder if he's even capable of doing. I'm sure he can get a personal trainer, but I wonder if he would, because I think that is the best medicine to keep bones healthy is weight-bearing exercises.
Absolutely right. 100% right. Right. You're right on the money with that,
Yeah.
for sure. So,
So whoever,
that's
for the audience, there is a podcast that we did recently, depending on when this is going to be published. This is probably going to be published within the next few weeks, on Biden and his situation. So you want to click back to that. Aaron, I have a question for you. A patient comes in. He has cancer in both lobes. One of the lobes, again, for argument's sake, let's say the left lobe is 2 Gleason 6s. The right lobe has 2 Gleason 7 or above. And this guy is very interested in his quality of life. He's maybe 58 years old, and he has a full life to live, newly married, so wants to preserve his sexual function. Can you treat only the right side and leave the left side alone and just kind of follow up on that with time, clinically?
Yeah, you're giving me a difficult situation, and one that does come up. And these are the kind of cases that we discuss in our medical conferences, because there's not a slam dunk answer to it. The first thing that I would do, if he's 58 and you presented that he has cancer on both sides, but one side not that bad, the other side is a little bit more concerning, is the concerning side, the Gleason 7, I guess he was a grade group 2, let's say a 3+4, is that even concerning for treatment? I would do a DNA analysis first, myself, with something called a Decipher test, a Decipher score.
Yeah.
And if he comes in with low risk and the other side is low risk, I would look at his MRI. Now, the MRI, as I said before, is important, because the MRI, if I'm going to put him on surveillance, meaning no treatment right now because he's young, and maybe we'll do treatment in a few years from now, his MRI has to be clean, meaning that there shouldn't be any bulge of the capsule. There shouldn't be anything outside the prostate. There shouldn't be any really significant lesions in the prostate. You get what's called a PIRAD score. You don't want to have a PIRAD 5 out of 5. That would be I would not put him on surveillance for that. But if he has a low PIRADS on MRI and a low DNA score, and he is motivated and willing to follow it, I would have a discussion with him about surveillance, because there are lots of studies from our good friend Lori Klotz up in Canada. University of Toronto, University of Michigan has studies, UCLA has studies, University of San Francisco has studies showing that even with a Gleason 7, a grade group 2, that these patients can be watched. If he wanted treatment, could we, as you mentioned, just freeze the more active cancer and then follow him, even though we're leaving cancer untreated? He has non-aggressive cancer, and maybe just get rid of the other bad player and put him back on active surveillance. And I think the answer to that is unknown, but I think that the feeling amongst many people that are doing ablation now is yes, he could.
Okay.
The other thing, that if he didn't want radical surgery, which again would be open to him since he has cancer on both sides, he is young, but you mentioned that he's really concerned about his sexual function, maybe he doesn't want surgery, is to do a program that we have here at NYU, as you well know, called CyberKnife, which is a form of what's called stereotactic body radiotherapy, which is 5 days of treatment with radiation just to the prostate. Now, not just to the cancer, it's a whole gland treatment, but many of the patients, not 100%, but many of the patients can maintain their potency, and this way you've knocked out both the right and the left areas of cancer.
Yeah, we've had Jonathan Haas on a few times talking about CyberKnife, and aren't they either doing now or soon? The amount of treatments is down to 2 potentially, depending on the case.
The 5 days to 2 days is under clinical trial investigation right now. It is not standard of care. We are enrolling patients in a clinical trial. You are absolutely right. The early results, I will tell you, look very good.
Oh, excellent.
For having the 2-day treatment, which is enormous. I mean, we used to go from 40, now we're going from 45 days of treatment to 5 days of treatment to maybe 2 days of treatment. And a guy named Dr. John Lishak, who recently left NYU and went to Georgetown, terrific guy, works with Dr. Haas, worked with him, initiated this trial. It is still ongoing. And we have a CyberKnife Center, as you know, in the city, as well as on Long Island, and certainly a great option for many men.
John Lishak has also been on the podcast and is published, so the audience can look for that. It's a great podcast around CyberKnife. Another question. So now you have a man that is 62 years old, and he has a Gleason 9 prostate cancer. PSMA PET scan shows that everything is encapsulated, nothing is outside of the capsule, and so he's adamant about not getting his prostate removed, and he wants to do cryosurgery for his Gleason 9. Decipher score may be intermediate risk, and he says, "Look, I'll sign the dotted line. I just want to do cryo, and I know that if it recurs or if something happens, that my plan B and C." Is it reasonable to do cryo on a man with a Gleason 9? Again, nothing has spread, where he's very adamant about doing cryo.
Well, again, it depends upon the MRI, Geo, and where his Gleason 9 is located. And if it's in one area of the prostate, where this could be what we call the nidus of the cancer or the stem cell, and this is where it's originating, and it's in that one spot, I think if he's an educated man and knows the options and doesn't want anything else and doesn't want hormones with it, and it's in one spot, we can ablate that one spot and follow him carefully. And he's had a PET scan, as you said, which is the right thing to do for a high-risk prostate cancer patient. That's correct. If it's all over the prostate, up and down his prostate, and his MRI shows his capsule is bulging, I would have to decline, and I would have to tell him, "Look, sir, I know what's right for you, and this is not." And even though I do lots of cryo, and I'm very honest with people, and that's why I think my reputation stands, because I'm not a one-size-fits-all. I'm a guy that has to sleep at night with my decisions, and I try to do the best for my patients, as you know. And I will tell him flat out, and his wife, "I'm sorry, this is not right for you. You have aggressive cancer." And now I can use the Biden example. Look,
Right.
You don't want to wind up like this with a Gleason 9 with it spread.
Yeah.
You need absolutely to have, I would say my number one option for you at 62 is I'd get my prostate out. If you're telling me that, and robotic surgery today, first thing that I want to do is I would go into, why are you fearful about surgery? What is your fear? Let me see if I can help you there. Are you fearing that you're going to need blood? Well, you know what? Our transfusion rate, almost zero. Are you feeling like you're going to be in the hospital long? I'll tell you right now, if we do your case at 7 o'clock in the morning, we can get you out at 4 o'clock in the afternoon. Are you fearing that you're going to lose your urinary control? I will tell you that you probably will have a little leakage for 2 to 3 weeks. And by after that, at least you're not, as long as you're not significantly overweight, you will dry up. You will not be incontinent, okay? Well, what about my erections? Well, you know what? You might lose your erections. Yeah, because you have a Gleason 9. We may have to sacrifice your nerve bundle. So you know what? You might need Viagra. You might need Cialis. You might need an injection therapy. You might even need an implant. But at least with good certainty, we can get you cured. And you're not going to wind up, because if you wind up like Biden, where his cancer is spread and metastasized, you need to be on hormones, you can forget about your erections. Forget about it. It's done. Your testosterone is going to be in the tank. So I like
Yeah.
to explore and say, you're telling me absolutely no, you don't want surgery. Why don't you want surgery? What is it? Let me see if I can help you there. Okay.
Sometimes the patients are kind of made up their minds is a tough nut to crack.
Yeah.
This patient says to you, Dr. Katz, Gleason 9, please treat it. Is localized, and then of course I'm going to see Dr. G. I'm also seeing Dr. G for aggressive lifestyle intervention. I mean, I'm going to do everything he says to the T.
Okay.
You'd
Love it.
say same thing.
I say I love it. I go absolutely, and that's why I think this is an integrative approach. This is a complementary
Yeah,
approach. We're
sure.
complementing each other, It's not like you just go to see me and I'll take your prostate out and see you later. No, you need to
Right,
get your life under control. You
right.
need to get your
Yeah,
and do all the things that you do in your practice. And that's why, we're so grateful to have you here at NYU. So, I think you're right that people come in with preconceived notions about a lot of things. They're
right.
anxious. They hear that their neighbor had prostate
Yeah,
cancer,
yeah.
or their father had prostate cancer. It was removed, and their father leaked urine all over the carpet. But you know
Mhm.
what? Your father probably had an open radical prostatectomy, not with robotics. And it's
Years 20, more maybe 20 years ago, 25 years ago, which is so
yeah,
different. I have
it's
to I have to
completely
admit.
different. It's apples and
Yeah.
oranges. You can't compare it.
Yeah, it's artistic. What you guys do in the operating room is the most unbelievable thing. I'm still in awe after all these years watching surgeons do what they do and removing the prostate. No question about that.
I agree.
Adverse events these days after cryo, what does that look like? So, what are the most common adverse events that you see these days?
I think probably the most common one still is the erection. I think most of the guys come through it. They have a
With cryo or prostatectomy?
probably both.
Okay, okay. So even if you're treating half the gland, and let's say the person in a scale, because most people are still not familiar with the Shim score, but in a scale of 1 to 10, 10 being that I get great erections before treatment, and 1 being I don't have any erections. Let's say there are 7 or 8. You treat half the gland, or you treat it focally. Is that number for erection still? You would still say it's high?
I would say that it's your erections are going to go down a bit, and you might need some, even if you do a focal ablation. In about 30%, about 70% will maintain it, but a 30% will not, and will need some medication, Geo. Yeah.
What happens? So you treat the prostate with cryotherapy. You freeze it. What happens to that tissue? How does it? Is it still there to some degree, but it's not obviously it's frozen? Does it stay frozen? Does it disintegrate? What happens to that tissue?
The tissue does not stay frozen. It's only frozen for the duration of the procedure. It stays there and it kind of involutes, what we call, or becomes a fibrous scar, so that if you biopsy the material, you shouldn't see any glands there. The glands should be eradicated, the prostate glands. The stroma, or the scar tissue, might be there. You'll still be able to do an MRI and see the prostate. But today, when we do an MRI and we give gadolinium, which is the contrast agent, it shouldn't light up in that area and it shouldn't show any cancer. So that's the way that we follow patients after an ablation of cryo. Of course, as I mentioned earlier, your standard PSA, and you'd like to get an MRI on people usually 6 months to a year after. There's no hard and fast rule. There's no real consensus on it. I think the consensus, at least in the focal therapy society, is that you should get an MRI, usually at least within a year,
Mhm.
to make sure that there's nothing there. But, and if there is something there, you can always biopsy it.
When do you and why and in what scenario would you have to would you have to do another biopsy in a patient after cryo?
I don't do a routine reflex biopsy. I know that Dr. Lepore and his team, when they're doing their research, and they've done a great job at it, do reflex biopsies. I think he's doing it at 6 months and then at 3 years, I believe. or maybe they're just going to the 3-year biopsy now because their data looks so strong. For me, it's more about the PSA and the rise in the PSA. If it usually goes 2 points above its lowest, I'll do another biopsy. Or if I get an MRI and it shows a new spot, I'll do a biopsy. So,
Excellent.
yeah. Geo, I want to thank you for this opportunity, and it's great to see
Absolutely.
you're so successful and doing a
Thank
great
you.
job here. And I hope it was helpful for your listeners. There's not a one size fits all out there, and I think people should get a second opinion. Certainly, I've got my NYU shirt on, but I'm, biased. I work at NYU, but we are a comprehensive cancer center.
Yeah.
We are a center of excellence. We're number 2 urology program in the country. We're a center of excellence for prostate cancer, and certainly we are open for, seeing you. We can do a telemed visit on people if they live outside of the region. We can see you in many locations on Long Island, in Manhattan, and to get a second opinion and go over your biopsy, your MRI, and go over your options. And we
Right,
really
Doctor.
are a
Yep.
state-of-the-art center for robotic surgery, for focal therapy, and for stereotactic body radiotherapy. So we really, and
Truly comprehensive.
active surveillance because of you. So we really are a
Truly
comprehensive.
comprehensive. Yeah.
Yes, absolutely.
Dr. Aaron Katz is the chair of Department of Urology at NYU Long Island, and one of the best, certainly in cryotherapy, if not all of prostate cancer. Dr. Katz, thank you so much for being on. Again, a pleasure to have you on. I think those were your final words, perhaps, if you have anything more to say. If not, how can people find you?
Well, the NYU folks, if you're an NYU patient, certainly the My Chart, you can find me there. You can find me on the web, of course, as part of the NYU system. If you just plug my name into Google, it'll show up on an NYU. And the phone number, if you want to give us a call, is 516-535-1900. And that number, you can see us on Long Island, or you can see me in Manhattan, Madison Avenue and 55th Street at the Men's Center. Thanks again,
Beautiful.
Gio. Really
Thank you.
appreciate it.
Thank you, Aaron. Thank you, everyone, for watching this episode on cryotherapy. You've had a lot of questions. We got them answered, I hope. Thanks again. Keep thriving. You're not just surviving. If you've had prostate cancer, you're a thriver, prostate cancer thriver. Much love to you all, and I'll see you next time. Dr. Geo here, signing off.
We hope you enjoyed this episode. You will continue to receive powerful interviews and insights to support your prostate health journey. For those who want to dive deeper, our exclusive membership offers even more.
If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgeo.com. I'll see you next time.